The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The webinar will begin shortly. Please remain on the line. The broadcast is now starting. All attendees are in listen-only mode.
Well, good morning or afternoon and welcome. EMS research enthusiasts to the December 2017 PCRF Journal Club. As you all know, the Pre-Hospital Care Research Forum is dedicated to the promotion, education, and dissemination of pre-hospital research. We believe that it is the responsibility of emergency medical professionals worldwide to build a body of evidence to examine pre-hospital emergency care. Here with the PCRF Journal Club, we take a closer look at some of the latest research happening in EMS. I'm Megan Corey, and I'm joined by Dr. Bill Toon, Dr. Tony Fernandez, and Sean Britton. The study we will be reviewing today is entitled Pre-Hospital Pain Management, Disparity by Age and Race. This was published in Pre-Hospital Emergency Care in November of 2017. This review, as usual, is paired with an article written by columnist Dr. Tony Fernandez in EMS World called The Trip Report, Turning Research into Practice. And we encourage listeners to check out this article. We'd also like to announce a few upcoming research opportunities in the new year. The deadline for new abstracts, both educational and clinical, for both the 2018 National Association of EMS Educators Symposium and the EMS Expo International Scientific Symposium will be on April 30th, 2018. We will be sure to provide monthly reminders before our podcasts about these exciting opportunities for you budding researchers out there. So thank you all for joining us today. So let's jump in, and we want to remind listeners that you can use the chat feature on your screen to type in questions and comments. It should be over onto the right side of your screen, and we'll bring those into the conversation as we go. So let's get started on pre-hospital pain management, disparity by age and race. And Dr. Tony Fernandez, can you take the lead on this and give us some background on this study?
Yeah, absolutely. This is a really cool study. What they did was they had a question that they wanted to answer that was related to pain management in EMS. And there are a lot of different ways you can go about answering this question. You can look at your agency, you can look at your county, you can potentially look at your state. But there's one really neat way that you can get this information on a national level, and that's to get it directly from NEMSIS. It's not Nemesis, no matter what people tell you. It's actually NEMSIS. It stands for the National EMS Information System. NEMSIS is great in that EMS is one of the few healthcare professions that actually have a nationally standardized data set. So what that enables us to do is compare essentially apples to apples if we're looking at data in California or if we're looking at data in New York, or anywhere in between or above or below. So it's a really robust data set that we can get a lot of information from. NEMSIS is currently they're currently releasing their version 3 of their data set. So if you go on the NEMSIS website, you can download the data dictionary for the NEMSIS version 3. The last 2 years, they've been transitioning from their version 2 data to their version 3 data. And what that means for states is that they're going to have to collect data a bit differently. However, the version 3 data set is going to give a lot more, it's going to be a lot more robust, so you can dig in and get a lot more information. They did use their information, they got their data using the version 2 NEMSIS data. And one of the great parts about NEMSIS, again, is that almost every state submits data to NEMSIS, and there are actually a few states that require 100% submission for every PCR that's completed in that state. And even better, NEMSIS gives you the ability to request a research data set annually. So all these data that you put in are not just going into a black hole somewhere. Investigators and interested parties can actually request this research data set and answer whatever research questions they have. They also have a data cube on their website where you can, you won't get a data set, but you can ask and answer specific questions related to NEMSIS, related to pre-hospital patient care. So it's a really great data set, and this is one of the first studies to use it on a really large scale to answer their question. And I think as we get into it, we're going to be impressed at some of the things that they were able to do with this data set. And obviously with every data set, there are some limitations, and I'm sure we'll talk about those some today also.
Great. And just to remind listeners, the NEMSIS website is nemsis.org. That's NEMSIS.org. So you can check out what Dr. Fernandez has been referring to, including all of the updates, version 3 updates, et cetera. All right. So, Sean, I think you were going to take us into what this, the methods of the study. What did the authors look at?
Thank you. So thank you very much, Dr. Fernandez, for the backgrounds on NEMSIS. The researchers for this study did use the NEMSIS database in order to gain raw data for analysis through the public release process, which interested researchers can pursue through that website in order to gain data for their own research purposes in the future. And the authors of this study used data from 2012 to 2014. And if you advance the slide just one for me, you can see on the left there that when they polled for those 3 years from the data set, they came up with over 69 million records. And what they were looking for was patients that had certain CMS codes assigned to them, which you can see in the middle box for fractures, dislocations, amputation, burns, and penetrating extremity trauma. They wanted to find patients who had conditions which are known to be verifiably painful, and then exclude the others which did not meet that criteria. They also wanted records in which the patient was treated and transported by EMS. Among the remaining calls, they then had the 276,925 records, which you see. From that, they divided the patient into groupings based on age, and there were 5 broad categories they used. And they were also looking for patients who had a primary or a secondary report of pain as a symptom by the provider. Using that, they also pulled data on whether or not medications for pain management were administered, and they were trying to determine how aggressively patients are being treated for pain and how they are being treated in these cases. And then they did a further analysis based on age to determine whether or not there was any sort of impact based on how old the patient was compared to other patients. And then lastly, they then reanalyzed the data to also look at whether or not race and ethnicity were a factor in whether or not pain was treated. And with that, I will pass it off.
Okay, Dr. Toom, would you like to lead us through some discussion on this? Oh, is Bill around?
Yeah, I had to unmute my
Sorry to get you off guard.
my mic there. That's okay. Well, there's a couple of things I want to just discuss before I get into even what the authors had in their discussion section. And I think one of the things to look at now is with pain management in general is the big issue with opiate abuse. And I think that it would be, in my opinion, the acute management of pain shouldn't inhibit a pre-hospital care provider from managing that pain with the appropriate pain control medication. I don't think we, the pre-hospital care provider, is contributing to the opiate crisis. And I don't think it should limit us from taking care of what patients' needs are in the care that they should receive. So I think that that's something very important to just get out there up front. And knowing that this study has been going on, I mean, the data from the time frame is during this whole growth of us into this current crisis that we have with opiates. So we're just talking about generic pain management, I think, at this point here, and as it relates to the study here, but it shouldn't inhibit us. The other thing is I'm impressed with them using the database, and I think that that's where we can spend a little bit of time talking about what are some of the advantages of using a database this size, and what does it really help us understand about the overall EMS population. And Dr. Fernandez, I know, gave an overview of it, and I was just curious if any of the other members of the panel have actually ever used this data set that's provided by NEMSIS and what some of their experience has been with it. The silence answers that question.
Yeah.
So this is Tony, and I haven't specifically used the NEMSIS data set for quote unquote research purposes. Typically, I work with 3 states, and we collect NEMSIS data. So the analysis that I do are often on NEMSIS standard elements. So I can speak to what is in the data set and how some different things that you can do. The NEMSIS research data set I've used internally with the states to kind of benchmark state performance against the national data set. There are some limitations to NEMSIS that we can certainly talk about in terms of using it to specifically compare. So one of the examples I gave earlier today was that you can compare apples to apples if you're looking at California and New York. That was a little bit too simplistic. Actually, NEMSIS, while they do collect state level data, they don't have approval to release data that identifies the state. They can identify a region of the country. So you can't necessarily compare your state to another state, but you can compare your state to the nation as a whole or to a region. And you can do the same with your agency.
What have you, even at your state level, one of my things that I see as concern when I watch people complete patient care reports is the quality of the data. So I think that some of the quality could be, I'm going to try to answer this question, could be less of an issue because of the absolute volume that they have here that they're looking at. But it still doesn't mean there isn't problems with the quality of the data that's entered. You know, as a sense
I completely agree. I think that you'll find, though, that with any large data set, you're going to have issues with data quality and element completion. That's just territory that's going to be there. That you'll find that with registry data where you have people who input data, and you'll find that with data where PCR data are imported from a third-party software vendor to a state or to the national data set. I think that's kind of something that is inherent with large data sets. The good part about the NEMSIS data is they're currently on their version 3 release, and if the data has gotten from version 1 to version 3, the data quality and completeness has gotten exponentially better. NEMSIS actually has a dashboard on their website where you can look at the completion percentages for the elements that they require, and most of them are in the high 80s and 90s. They have a red, yellow, green scale where they look at completion of these elements. So I will absolutely admit that this data set is not perfect. And by the way, just I have no conflicts here. I don't work for NEMSIS. But the data set is not perfect, but it is leaps and bounds better than where we were. And because it's a nationally standardized data set, it is leaps and bounds better than any other healthcare field.
You know, and let's dive into, let's relate what we're talking about now to this study itself. So when we talk about the quality of data, we're actually we're looking at the same data. So all of this is being drawn from the same data set. So does it really, I mean, you know, if it's all, you know, I don't want to say garbage, but if it's all, you know, it's kind of data that you know, has its limitations, we're still doing a comparison of that data within the data set, within the context of this limited data set. So, and that's what this study is really about. So when we do look at it, the 69 million EMS activations, right, submitted to NEMSIS in that 4-year time period, 2012 through 2000, or no, 3 years, 2012, 13, and 14. And then of those, 276,000 or so 911 initiated EMS activations that had patients that were had a primary impression of the types of injuries that they selected for, that they thought would be most likely to receive pain management of some type, fracture, burn, penetrating injury, something. I'm not sure if I'm missing anything there. And then the documentation of pain as a symptom. So we know that piece may be affected by, inconsistent data entry. But then when we reach into that data and we start comparing groups, now all of a sudden the limitations, we kind of shift the mindset. So we're still comparing within the limited data set. So we might say, well, yeah, maybe pain is underreported because we, number one, we're not using a pain scale, which would probably be a better way. And they mentioned that it's not a pain scale or standardized patient assessment for pain that we're using in here. So it's just really a matter of, do they document the complaint of pain or not? That's still limited in general, but when we go down to compare the two, there's no reason to believe that it would select one category of patient over another, unless you guys disagree. But there's no reason that it would explain the results that they're seeing, the disparity in age group, or maybe an age group, because you've got the pediatric age group of 0 to 3 is not exactly going to say, I have pain, but in the race breakdown in the racial disparities, there wouldn't necessarily explain a difference there as to whether or not someone might document, unless there was a language barrier or some type of communication or issue. So we're still kind of comparing within that data set.
And I agree with you, and I think that that's where the discussion goes, is when now we look at who they identified as their actual population in the data set, excluding everyone that they talk about. I think that we're still looking at what we can say is a small, they talk about what percentage of all EMS calls are pediatrics, and then where the pain management is of this subgroup. But we now can go look at this subgroup of people that have been identified and decide, hey, what can we learn from this information and stuff? And I really like what you talked about when you talked about documentation. We're not unique. Pre-hospital care providers are poor documenters, just like the rest of healthcare appears to be.
Something else is that, assuming that the data was entered correctly in all these cases, what we're missing from the data set as it stands is the reason for why. And so we don't have a NEMSIS data field for if care was declined by a patient's caregiver because of previously held social cultural beliefs about healthcare or EMS. And so we don't have a good understanding from the data set present of whether the medication was withheld or whether the medication was asked not to be given by a caregiver. So while we have this broad national data set, we lose some of that granularity we can get from a more focused, smaller level study where there's interaction with the participants rather than analysis of a data source.
Exactly. And I think just to summarize some of the results, and really the primary issue here is that administration of pain to patients over 15 years of age with documented pain was varied by racial group with a statistical significance that was pretty solid, p-value of less than 0.001. And that EMS activations that involved Black patients in particular with documented pain were less likely to be administered pain medications. So what we don't know, or what are the confounders that, and this is what Jamie Kennel brings this up in one of our questions that was posted in the chat area. What were some of the controls on these variables? They're confounding variables that might affect patient race and their effects on the dependent variable, which is the administration of pain medications in particular. And I think you bring up a really good point. Sean, what about, we don't know about the patient's choice in the matter too. Given the prior history of African Americans in this country in particular with Tuskegee and others, the suspicion of the medical establishment, how much did that affect the administration of medication, the choice to administer the medication or decision to, agree to receive medication?
So this is Tony again. I just want to, make a comment about the data analysis. It looks like from the data analysis section, they calculated proportions, 95% confidence intervals, They ran some chi-squared analyses, but they didn't, as if this data analysis section is complete, as it is published, they didn't do any type of regression modeling where they would control for confounders. So this is I would suggest that these are crude, and you have to think about these results as if there's the individuals have a blinder on, and not looking and just looking at, for instance, race and pain management and pretending nothing else in the world matters.
Now, why would that be, Tony? I mean, what is NEMSIS capable? Is the data set capable of being mined for things like associations with other confounding variables? I mean, what other things are collected that may have been? I mean, for example, they didn't combine they didn't ask gender at all, and they didn't combine age and race at all, and say, well, were there more patients in a particular category that were also in another, or also in the 0 through 3 age group, for example?
Yeah, I think that it's unfortunate. A lot of times we have the investigators on, and we can ask them. So I'll have to guess. I know, and I can tell you from firsthand experience that you can. There are enough data and there are enough variables in NEMSIS to run logistic regression models where you adjust for confounding variables and interactions and other important variables. I think it has to go to essentially what their outcomes of interest were. They wanted to. They have 4 stated. They wanted to see if pain was recorded as a primary or associated symptom. They wanted to see if the patient received any type of medication in age category. They wanted the percentage of patients in each age category receiving opiate analgesics or over-the-counter acetaminophen, ibuprofen, or nitrous oxide. And they wanted, for the patients with pain as a noted symptom, the percentage who receive any pain medication. And then they wanted to look at age cut as less than 15 or greater than or equal to 15. So nowhere in there do they suggest that they're going to give any type of adjusted proportions or odd ratios or anything like that.
Yeah.
This is just a raw analysis.
Yeah, and I think that's a really important point.
Yeah. So this is a descriptive paper, as pure as it can get, and I think when interpreting these results, it's important to understand that you take them with a grain of salt.
Well, I think it's important too for those who are out there thinking of, if there's students out there that are just learning research, or they're thinking about putting together a research project, or even interpreting published research, the place to begin, besides the background and learning why the research is being performed and the importance of it, is to look at what the objective was. And I think you're right. You go right back to what were the objectives of the study, and did the authors, did they state that they were going to look at any detail greater than what they published? So I think that's a really important point. A few comments that were made also here on our chat room. Robert Steeps says another potential confounder is transport distance. I didn't even think about this one. Population in an urban area with shorter transport distance versus a population in a rural setting with longer transport times. So again, what people are coming up with are the potential confounders that could explain the outcome other than what the authors have attributed, which they haven't really. They were just pointing out, again, description. Are there disparities? Is there a difference?
And just to add in there, they do talk a little bit about a route of administration, and they talk about fentanyl and intranasal and the fact that it can speed things along. But the other factor we don't know in here is how liberal are the protocols that paramedics are working under? Do they have the latitude to administer pain medications without contacting medical control? I mean, so there are some other barriers that could be impacting the ability for them to administer pain medicine. And transport, if it's a short transport time and you have to talk to the medical control, sometimes the opt is just let's get them there quickly and let the hospital start the pain med.
We also don't know ALS versus BLS. So how many of these patients could have even potentially received the medication from the EMS provider they were receiving care from?
That's true. And I was kind of combing through and looking for some of these things, or at least sometimes in the limitations section, and authors will address some of the things that we are talking about, saying that this study is, it's a descriptive study based upon a very large database. That is, I think, one of the things that they highlight in terms of a strength is that this is a very large database, although, as they say, it may just represent a very large convenience sample, since not all EMS responses are included, of course. But it does represent the largest national EMS database and the starting point, basically, to looking at certain things, and then we can kind of carry it from there. There are limitations that they address are that the data quality, like we've been mentioning here, they're dependent on the diligence of the providers entering the data, that there weren't any pain assessment scores that are collected in the NEMSIS database, and that's been, a new standard. And we should point out that the National Association of EMS Physicians and the National Association of State EMS Officials, NASEMSO, have the National Model EMS Clinical Guidelines recommendations that do point to a mandatory assessment of pain using a validated pain assessment tool. So that might be something we see changing. And I'm not sure, Tony, if that's going to be in a newer version of NEMSIS or not, but that's a recommendation I know that's coming out. Also that in general, race and ethnicity is poorly documented by EMS with noted missing values commonly. So that may be, again, a quality of data issue. But they do say something that I have to say I completely agree with this, that, sometimes we might say, well, that the actual race or ethnicity may, is determined by the EMS provider. So that, we don't know if it's self-reported or if the EMS provider has entered it, but that whatever the provider enters may actually be more important because it's the perceived race or ethnicity that may be more important in determining its influence on pain management, if that is an element of determination of pain management in what we're seeing in the disparities. So the other thing they bring up is multiple activation records for the same patient encounter. That could result in inaccuracy of the analysis because you have multiple providers, first responder provider and the transport provider. So you may actually have, and they don't have a way of controlling for that at that point. I'm not sure, again, if that's changed. And again, the large convenience sample. So Tony, do you know if any of these things will change with new versions?
So it's really hard to say with the new versions. The NEMSIS 3.5, right now they're accepting 3.34 and 3.4. The NEMSIS 3.5 is supposed to be released in March with a deadline, and I'm sorry I don't have this in front of me, but I believe the cutoff deadline where they will stop accepting 3.4 and start accepting 3.5 only is in 2020, but that we don't actually know what's going to be in 3.5 just yet.
And Megan, if I could just, one of the things that you talked about there before, when I worked for a county agency, it was interesting that a lot of the providers were unwilling to fill out the race for a patient at all. They felt that was unnecessary information to collect, and that was the most commonly blank field within our data set that we had. And there was even and along with weight was the other one, the two areas that they just were totally reluctant to do any kind of documentation in. They felt they were opening themselves up to some kind of unknown potential litigation down the road.
Yeah, or there's really no guidance. I mean, we've really provided no guidance on the importance, and B, how to even begin. Is it self-determined? Is it? That's interesting that weight is another category that's blank. And I would say it's probably people feel like might be inaccurate in their estimates. Gordy Cox also comments about the opiate crisis, something that was mentioned a little bit earlier, but he mentions the chronological issue. He said, given the time frame of the study, is there any chronological indication of an overall decrease in administration of pain medication correlated to the opiate crisis? And this was 2012, 13, and 14. And really, I guess what we would be thinking about is, does the presence of an opiate crisis and all the attention that's given to it, and maybe some medical direction that causes changes in the methods or the way that people administer opiates in the field, would that affect this over time? And we brought that up. We not sure. I mean, it just didn't really look at that, and we don't know. I don't know if anybody has any idea if any of that has changed in your area or in other areas in terms of have we swung the pendulum in the opposite direction and reduced the use of opiates in the field for pain? I haven't seen it locally here.
I haven't either. I would agree with Dr. Toon's earlier comment that in the acute phase, we're not really modifying our practice with regards to administration for acutely painful conditions.
Yeah, and we should note, too, that morphine and fentanyl were the two most common pain medications administered. And so those are, obviously both in the opiate category. So those, when they looked at just the overall of pain medication was administered, those were the two most common. They also make the comment about, they bring it up later, I think, in the discussion section about intranasal fentanyl. They're really advocating for it, it seems like. Having an easy, effective method for treating pediatric pain in particular, and avoiding a lot of the barriers in treatment, concerns over, safety and other things. Do you guys use NSAIDs in your areas? They mentioned ibuprofen being rarely used, and I know we don't usually see it out here either.
We utilize acetaminophen within the state of Maryland.
What's the decision tree? I mean, when does someone decide to use acetaminophen versus, a non-opiate versus an opiate, or is there guidance for that field use?
I apologize because while I passed my initial protocol test for licensure, I clinically don't practice much here. But from my recollection, it does have to do with pain scale guiding it, that a lower reported pain scale might drive you more towards an acetaminophen, whereas a higher pain scale would drive you more towards an opioid-based pain medication.
Yeah, and allergy, I guess, but... Okay, so we had another comment too from, I think earlier, from Jamie Kennel, pointing out that in the discussion section, the authors to give reasons surrounding the pediatric, actually not reasons, but advice about how to address the issue of the disparity in pediatric pain management in terms of training. It always turns toward training. Training must address some of these things, pediatric, and then they talk about using intranasal fentanyl as a possible effective and safe alternative with a good safety record for pediatric pain. And but I think Jamie was looking for some advice on how to interpret or address the racial disparity issue. And I think the authors make just one statement right at the end of the discussion that, again, says training must address racial, ethnic, and language disparities, which, again, that's a big issue, language disparities as well. And I don't know if NEMSIS captures that. And maybe, Tony, you can point to that. Does NEMSIS capture language disparity or communication barriers that might occur between the provider of healthcare and the patient?
So, yeah, excuse me. The answer is yes, they do. Now, the question, this is a simple question that's going to have a complicated answer, unfortunately.
Okay.
So NEMSIS has, there are about 300 NEMSIS required NEMSIS elements. These are essentially NEMSIS data points, and I believe there's over 300 now. However, a fraction of those are required to be submitted to the national data set. These are typically what happens is the state will require a host of elements that are a subset of every NEMSIS element. And then NEMSIS will require a subset of the elements that the state collects be submitted to the national data set. So there is an element for barriers to patient care, and in which it does talk about language barriers and other barriers that might be in there. What I'm checking right now is to see if that is both a state and a nationally required element, and it is. So that is something that could be accessed. Now, whether that is included in their research data set, I can't actually confirm, but I know that information does get to NEMSIS.
Okay, so that's an important one. But what's interesting about the question is is there a communication disparity will depend on the provider of healthcare, right? So if the patient primarily speaks Spanish and the healthcare provider also speaks Spanish, there's not a disparity there. But if the patient primarily speaks, Spanish and the healthcare provider does not, there is. So what it will tell us is if there's a disparity. It won't tell us beyond that, right?
That's correct. So it'll tell us. So the question, the element it's element E1201. And it's barriers to patient care, and the definition is an indication of whether or not there were any patient-specific barriers to serving the patient at the scene. And the things that are included are hearing impairment, physical restraints, unintended or unsupervised minors, developmentally impaired, language, physically impaired, speech impaired, and unconscious. So it'll tell it won't tell you the why. Well, it'll tell you the why, but it won't dig into the why.
Okay. So what's your sense of using this database? I mean, I don't know about you guys, but after discussing this a little bit, I feel a little bit unfulfilled, a little bit like and again, it's always nice to have authors. We'll do our best in the future to really try and get an author on here so we can dig at some of the issues that we talk about. One of the things that I think I feel unfulfilled about in this article is they don't really head us, they don't show us their future. Where are they going to take this? What's next? What's the next question now that we've got this kind of little bit of almost a teaser here that, wow, we see these disparities, and then a whole lot of discussion about what they might possibly mean. We have a lot of discussion in the area in the discussion section on pediatrics. They're saying several reasons for this discrepancy have been cited, possibly this, possibly that, discomfort with or inability of the provider to assess pain in young patients. Preverbal age, difficult IV access, fear of complications, concerns about calculating drug dosages, IV access not otherwise needed. And that's from other studies. They're pulling that out from other studies and just kind of plopping it here and saying, these are things that could possibly explain this. But we're not, and so I think it's a good idea that they link to these other studies. They're saying, yes, we found disparities in this large database, and now we're just going to draw the reasons for them to these other studies. But I don't know, I just felt a little bit unfulfilled, like, okay, but now what?
I feel like some research drives practice and some research drives future research. And I think this is the latter rather than the former. My takeaway from this is that when you look at the largest data set that's realistically available, there is a disparity. And now more research should probably be done in order to find out why, because the result could be very significant to our practice. But this study by itself, while it raises more questions, doesn't really tell us much about what we're currently doing.
But it also doesn't give us a good future statement too, and that's the one thing I think I was sort of left like, that's interesting. It would be nice to, they give us some limitations and they make the blanket statement about, training must address this. Okay, but what's next? Where do you want to go with this bit of information? Because it seems like most studies will say something about future research should look at these things, and make a couple of statements about the next thing we're going to look at. Digging deeper into this is this, and I didn't get that from this, and I don't know about, maybe I'm not reading it right. Maybe you guys can have something different to say about it, but I just felt like I sort of got to the edge of a cliff and I can't quite see.
I agree. I mean, it should, you'd want at least to call for, if you're not going to do it, at least call for someone else to run a similar analysis at a minimum, where you're adjusting for other variables. I would say it would be a good next step. There's also, which is surprising, and I'd love to talk to him about it. One of the authors, Clay Mann, actually is the principal investigator for NEMSIS. And one of the things that I found really interesting about this, some of the training things that they recommend, is they recommend use of a pain measurement tool.
Mm-hmm.
And I think most folks in the field actually use a pain measurement tool. And this goes back to a conversation we had earlier, where pain scale is a NEMSIS element. It is just one of the elements that is not required to be submitted to the national data set, so they didn't have access to it. So it may not be a training issue at all. It may just be an issue with access to data.
And you're talking about quality of data?
No, what I'm talking about is the investigators didn't have access to that data point, pain scale. It's a NEMSIS element, but it's one of that states can require, but it's not required to be submitted to the national data set. So I think the assumption that folks aren't collecting pain scales and a way to measure pain is not a valid assumption, because they likely are. It just isn't included in what NEMSIS collects, nor apparently it couldn't be in the research data set.
Yeah, I think I was getting at too that they don't sort of point to, and maybe they're limited by what they can say. You brought up that someone was a principal investigator of NEMSIS. Maybe they're feeling limited by what they can say, and they don't want to go overarching. But they do actually make some pretty big statements about what some of the possible reasons for in the pediatric population, you might see these disparities. Although they do link it and they cite it to studies, they don't make any kind of statements without any kind of cite to it. So as a scientist, I appreciate that. But I would say it would be nice to hear a few of their kind of, as researchers, what do they see on the horizon? For example, Robert Steeps also writes something from a sociological perspective. It would be interesting to study the race of the EMS professional in addition to the patient. If we find inter or intra-racial biases or barriers, this could be addressed. Attitudinal studies are fascinating to me, and that this is from Robert Steeps. And I would agree. I mean, there's no statement about, even a sentence about qualitative research that might dig into just a call for research, a call for things that might further, dig at this issue. And Jamie also says, she agrees with you, Tony, says surprising to be published with the kind of a crude analysis without any kind of controls. But pain assessment, she thinks, is a nationally collected element. So is that, and I'm not sure what you were mentioning, that pain assessment is a nationally collected element, but not the specifics of a validated pain scale. Is that what you were getting at? Yeah. So what do you guys think about this, just sort of not making any kind of statements about what kind of qualitative or quantitative research should be done after this? I mean, usually we see that in articles. Usually we see a follow-up that says, further research should look at this, this, and this. But we don't see that.
Megan, it makes me think how we've been very fortunate in the past few months that more often than not, we've had an author join us, and sometimes they're able to provide insight and background information we wouldn't otherwise have from the paper through the conversation. And this makes me think an aspiring researcher that it's important that the paper be able to stand on its own. As fortunate we are to have authors who provide additional context, when something gets published, you really want as many of these questions to be out there from the get-go so that the reader who's never met you can take away what it was you really wanted them to. So I think it would have been very beneficial in this case for a call for future research to be included.
That's a great point. Bill, do you have anything to add to this?
I'm just going to add the thing that we always have to remember, that they took a step out there and they did some research. I'm not sure if it's clear how they got the funding or if this was a department funding, within their emergency medicine group, but it's still exciting that they did it. They did look at something, and I think it shows one of the things they talk about there is the potential and what we can learn from the NMSIS database for future opportunities. And, while there's always opportunities to improve one's research, I'm still excited that they did it and they brought it out there. I'm not sure it answers my questions that I might have in my mind, like what's next, but that certainly is there, is what is next with this and what can we learn from it and dig into it deeper.
Yeah, that's a really good point. Tony, do you have anything about, what do you think NMSIS should be looking at, or what kind of exciting things are on the horizon with looking at NMSIS, in particular, as it relates to some of the other things that are being developed, like the model clinical guidelines?
So I think NMSIS, it's hard to say what they're going to do next, because they're right in the middle of transitioning to version 3 and looking at what's going to be in 3.5. And I know that there's a lot of discussion in and around being able to use state level data and identify states. That was a conversation that was at the last, maybe the NASEMSO meeting before the last NASEMSO meeting. For those online who don't know, NASEMSO is the National Association of State EMS Officials. So these are all state directors, and they essentially tell NHTSA what NMSIS can and can't do. So that is certainly something, and they're looking to provide some more outcome data, working with states that do have those linkages, to have that available in the national data set. Now that's going to be a slow go, because not even every state, not even every county has that. But those are some of the things that they're actually have stated specifically that they're working on. The other thing that they're working on, one of the things that they said in this paper that was a limitation, was that when there could be multiple PCRs for one event, and they don't have a way to tease that out. I know that one of the things they're working on for version 3.5 is to have a specific ID for patients, so they can get around the issue of multiple PCRs for one patient.
That's good. That was something that I thought was concerning. I was surprised they didn't have sort of a unique number or a unique identifier that would be linked to a patient, or to be linked to a particular call. I guess couldn't be to a patient, because you'd have multiple. You can have a patient calling multiple times as well. I think Robert also points out, Robert Steeps points out that there are, and agrees with Sean, that there are many changes that are made to a manuscript during a peer review process. So there may have been editorial limitations as well, and sometimes the publication will put limitations on the authors, or they may ask, the reviewers may ask that something be removed, or that certain things remain only within the realm that they can be cited by other research, or something like that. And the fact is, we don't know that without having the authors here. And so I'm going to just kind of reach out here to our listeners and say, we're going to really continue to make every good faith effort to get an author on, because we find that we can answer your questions so much more fully when we have somebody here who's actually performed the research. And a lot of times we have these questions written in the margins of our articles, and then when we have an author, they're able to very easily answer and address that, and also recognize the limitations of the research. So I think it makes for a much better session here. So we'll do our due diligence on that part for our listeners.
Hey, Megan, I just wanted to jump in there with one other thing that we were talking about. Do you know, think about it. We're on NEMSIS coming up to what he said, 3.5 or something like that. At one time, there was no way to collect national EMS data. And I know some systems now on a smaller scale, but it talks about the potential for the future, are totally integrating their dispatch record with the pre-hospital care record, with the hospital record, so it can tie into also their community health practices and stuff. So there truly would be the development of a patient record where everyone would have access to all of that patient's information, and it will be HIPAA protected and everything. And so the potentials in the future are great, and abuse. Certainly, I know people that may feel that way could exist, but I think there's great potential in the future for us to even gather more information, meaningful and helpful.
See, now there would have been a good future statement. So I don't know. I just maybe I'm being idealistic, but I like a little bit more of a future statement. There also, truthfully, there wasn't any acknowledgement about any issues of diversity in EMS in terms of what is the breakdown of providers. And we know this from the practice analysis. We know that EMS providers are largely white and largely male. So this actually is something I think would be an important thing to at least acknowledge within the manuscript. And I think it probably was assumed. I think that most people know this, but maybe not. So I think, and maybe they didn't want to draw any kind of conclusions. They wanted to just let the data lie where they are, and recognize that there are other studies that have indicated there were racial disparities by race. And actually, I was kind of surprised they didn't mention gender, in particular in pain management. But they recognize other studies, both hospital and out of hospital, that recognize this. So maybe they just wanted to, again, just look at the large data set for that is NEMSIS, and start just kind of mining that data and checking out what we can see from it so far. So we're down to the final minutes here. Do you guys have any final comments? How about, let's start with Sean. Do you have any final comments to make about this research?
Just that despite the limitations we've discussed, it is great that the researchers went out and did this work and put it out there for us to be able to discuss today. So kudos to them, and thank you for the ability to participate.
Bill?
I'm here. I agree with Sean with everything that he says, and a great credit to the authors for just doing it and getting it published. That's a lot of effort right there. And just to tag on to you, not only the practice analysis, but look at the LEADS data, the longitudinal EMT demographic study. That provides, I think, even a much better picture of what's going on. And they're well into LEADS 2, so there's almost 20 years worth of data there. And that really talks about the makeup of our profession and stuff, and the benefits of that. Maybe that's one of the things we should talk about, is have some people from LEADS come on here and really talk about what is our profession in that sense.
Oh, great idea. Thanks, Bill. And Tony, do you have any final comments?
Yeah, I think this is a great, there aren't many papers that are published with NEMSIS data. There's a handful that I'm aware of. I think that as more and more people find out that NEMSIS data are available for research purposes, they'll be using these data in more and kind of doing more sophisticated analyses on these data. And I think that'll benefit all of us. So I think this is kind of a step in the right direction, and an idea of what's to come.
That's great. Thank you. And we're going to be ending here with a few minutes to spare, but we want to thank everyone for joining us, and remind you just at the very beginning, we announced that there's going to be a deadline for new abstracts, both educational and clinical. We're going to remind you each month now, so that we know those budding researchers out there. Now you get a little taste of maybe I can do this, and maybe we'll be interviewing you one of these times on our podcast. But the deadline for these abstracts, and this is for both the 2018 National Association of EMS Educators Symposium and the EMS Expo International Scientific Symposium, will be April 30th, 2018. And again, we'll keep reminding you and encouraging you to jump in this research pool. Thank you all for joining us. And if you are interested in presenting in an upcoming article, please email Dave Page at dpage@emsed.net. That's dpage@emsed.net. See you next month.